Hi. Perfect. I think it is sharp 8 o'clock. So let's start off. So thank you everybody for joining for today's session. Definitely it's indeed a pleasure to do one of such kinds, which is going to be an intense case-based discussions, which is more focused on practical rather than on the theory part of it. So definitely by the end of this, you all will get probably an idea how to go about for treating diabetes in a very different perspective. So first of all, I want to welcome all my panelists. So let's start with Dr. Girija, one of the very famous known personalities. I don't think she needs a lot of probably introduction. So whoever has attended any conference, the conference doesn't go without Girija ma'am. So she's our director as well. And a very down.
You got muted, Soumya. Soumya, you need to unmute.
Sorry. Yes. So a very down-to-earth personality who is always full of. Thank you, ma'am. Thank you for joining for today's session. That means a lot. Thank you so much. And yes, we have Dr. Adisi, who is the assistant course actor for our HRO. She is the one who is behind this HRO. So definitely you will all feel the flavors, how it can help you to become better clinicians. So it's irrespective of
age, aloha, or to others.
Sorry. Okay, somebody has 1 second. Let me check who has an issue. Aisha, are you there, dear?
Yes, ma'am, I'm here.
So just check, okay? Yeah.
Okay, ma'am, I'll check it.
Yeah, thank you so much. Then we have Dr. Davashri, again, one of the very familiar names. So a very famous practitioner in Salem. Anybody, whoever is there from Tamil Nadu, you would know her, and a very great friend, and we have been associated for a very long time. Thank you, Davashri, for joining. And yes, I have Richard, one of the youngest members, but very active. So I'm sure she would be adding a lot of value to the discussion. And not to forget the MDT person, the endocrinologist, Dr. Senthil Raj. Thank you so much, sir, for joining for today's session. I know it was a short notice and you could join us today. That really makes our life easier because we need not worry about the other part which you would take care. Thank you so much for joining. So guys, I'm going to do it in a very different way this one. I am the moderator. For people who don't know, actually, I'm Dr. Soumya. So I'm the chief mentor and co-founder for StudyMEDIC. So I will be playing the role of a moderator, probably helping all you to bridge with the mentors and the students. I would request a couple of you to be the volunteers. If you could start putting in the chat box or raise your hand, then you will be the volunteers once we start up the session. Let's start off. Okay, so this diff doesn't have a voice. Okay, so what does this mean is probably the teamwork. Okay, so like the strength, the number, the teamwork, even this big shark couldn't do much for these dolphins. That is because they work hand in hand. And that's what we are trying to do today. To work hand in hand with all the different, probably different consultants and different departments, which would help us to deal with the patient better. So I have already introduced everybody. Let's move on. Session agenda would be, yes, we are focusing on today type 1 diabetes mellitus, because I'm sure GDM, all of you are very happy to manage, probably manage an unseen complication, which you didn't expect, an MDT overview of the problems when you get, and take home points. So this is what we are going to start with. I'm yet to get the volunteers' names. Guys, can I get the volunteers? It's very important that I need to get the volunteers. Otherwise, I will end up picking up the volunteers. So anybody who would want to take it, would be very simple ones, guys. You all know this. This is all in the clinical practice. Yes, guys. Nahid, are you there?
Yes, doctor. Assalamu alaikum.
Good evening.
Good evening.
Salam. How are you? Good evening. How are you? I can't see you anyway.
Alhamdulillah. I don't know my camera. I don't know it's blocked. I will try.
No problem. Don't worry. So probably I would start with you, and this is what we are going to do. This is a beautiful GIF which I really found. Like which the teamwork, which would help the bicycle to move around. So probably we would be doing the same thing. Okay, Nahid, so this is what your question is. Sweetheart, can you hear? Can you hear me?
Just 1 minute, doctor. I will just try to fix my camera. 1 minute.
No problem. Absolutely fine. Okay, so guys, I need volunteers. Please raise your hands. This would be a simple one. There are lots of people who are gonna give your exams. So I think you should raise your hand because it's all about talking and discussing.
Mrs. Shurbi, 21 year, is presenting to your clinic. She is known.
Sorry, who is this? Nusrat, you want to
Dr.
take?
Nusrat, yes.
Okay, Nusrat,
Yes.
if you want to take, please raise your hand so that I can allot you the thing, because there are 4 scenarios which I want to give step by step. So that's why I'm just
Okay.
asking. If you want to volunteer,
Okay.
will be giving you the next one. Okay.
Okay, ma'am.
Yes, perfect. Okay, Nahid. Nahid, can we start? Okay, before that, if anybody has any problems, Rabia, okay. Nahid, Nusrat, Rabia. Yes, okay. So I just want to know from all of you, like how many of you have your MDT team in your place? Like how accessible the endocrinologist for you? Is it that all the time you get an access, or you are the one who is treating, guys? You can put your thing in chat box also, like the difficulties, what you probably encounter. Okay, I'll wait for the message. Meanwhile, shall we start, Nahid?
Yes, doctor. I will see. Okay. Is it okay?
You're
Okay.
not-
My camera is not working.
No problem.
Okay.
Absolutely
Okay.
fine. Okay. So Nahid, you have a scenario where Mrs. Surabhi, who is a 21-year-old, okay, so she's coming to conceptional clinic. She's a known case of diabetes, okay, and HbA1c is 10%, the recent one.
Yes.
She's on rapid insulin, which is a short-acting. She's on 12 evening. She takes 8 in the evening. Not very regular with the medications. So what specific information you would want to know from her, or how would you deal with this patient?
First of all, I will introduce myself to her. I will ask about how she is doing. For me, her HbA1c is high, so I want to counsel her if she is really taking, she's complained to her treatment. She's taking her treatment on time. When the last time she saw her physician, and how she is controlling her blood sugar, how she is taking her blood sugar every day, because she has to take it 7 times per day. I want to be sure that she is really taking her blood sugar correctly, and she is compliant to her treatment. If everything okay, she is compliant to her treatment and she is taking her blood sugar correctly, I want to see when I will ask her when she last time saw her physician, because it is high. Her HbA1c, it's high, 10%, and I will counsel her that it is serious or dangerous to get pregnant now, because her HbA1 has to be less than 6.5%. So I will advise her to check her physician again. And I want to ask about her, last time she saw her nephrologist, about her renal function. I want to ask about her, the last time she saw her ophthalmologist to know when the last time she did the retinal assessment, because if she wants to get pregnant, she has to control her blood sugar, and she has to be done this investigation within 6 months. I will advise her to take a contraceptive for the few months. I will advise her to check her HbA1 every 1 month to be normal levels. I will advise her to take folic acid 5 milligram before the conception 1 month.
Okay, perfect. Okay, anything else you want to add, or are you done with the thing?
I want to ask full history. If I have time, I just only took a few target history for diabetic, but for me, I will take a full history about her illness when it was diagnosed, and I want to ask if she has another medical problem. I want to ask about if she has any surgical problem, if she got pregnant before, any complication in the pregnancy before. I want to ask about her family history. I want to ask about her mental history, if she's taking smoking or drinking or taking any recreational drugs. I want to ask about her body mass index, because maybe she will need nutrition to arrange her body mass index less than 27 body mass index less than 27 if she want to get pregnant, and to reduce any complication with the pregnancy. I will counsel her that if she want to get pregnant, better to her blood sugar to be controlled in the level just to prevent any complication, because if uncontrolled diabetic, it will have congenital anomaly. She may have high blood pressure, preeclampsia, DVT. So I will, and there is complication for the fetus and complication for the mother. So I will counsel her, it is better to arrange her blood sugar in the level that it will allow her pregnancy to get smooth.
Perfect. Well done. You spoke about everything, but I didn't hear you talking about LMP. Anyways, I will give
Yes.
Richa for the obstetric management. How did Dr. Nahid do the history taking? What do you think, Richa? What could have been added? What if there's
Dr. Nahid have told almost everything. Yes, we have to go with the LMP. We should always take a detailed history that almost she have taken. So yes, from her LMP, and plus, yes, we have to see for her blood sugars, HbA1c, we have to check, and then we should counsel her properly as Dr. Nahid have told.
Thank you. Thank you.
perfect? Well done. Thank you. Dr. Senthil, I just wanted to know what would your view on this, because her HbA1c is so high and she's on ACT rapid insulin 1218. So when the obstetrician refers to you, what are the steps which you would be taking for them?
Yeah. So good evening all. So first of all, I would like to ask how long she is having diabetes, because if she's having diabetes for longer duration, the chance of complication is higher. And second thing is, she's on ACT rapid only. Ideally, type 1 diabetes requires basal bolus insulin therapy. So she requires 3 times ACT rapid and 1 times basal insulin glargine. So she's afternoon she's not taking insulin, and at the same time basal insulin missing at all. So so I will change the regimen to basal bolus, and I will ask her where she is storing the insulin. That's very, very important from a diabetologist perspective. That's very, very important, because if you are not maintaining the cold chain properly for insulin, the efficacy will be lost. Efficacy will not be there. The insulin efficacy will not be there. So we should educate them to keep the insulin in the door of the refrigerator. Nowadays, most of the patients will be having a refrigerator, or else if a refrigerator is not available, if patient is not affordable to that extent, we should tell them how to maintain the cold chain without refrigerator, and where she is taking insulin, because sometimes the patient will be taking insulin over repeatedly over the same side, either over the thighs or the abdomen or the arms. If they are injecting over the same side, what happens? They will develop lipohypertrophy. If there is lipohypertrophy, what happens? If you are injecting insulin subcutaneously over the lipohypertrophy side, the insulin absorption will not be proper. So they can land up in hyperglycemia and sometimes hypoglycemia. So that's very important to inspect the insulin injection site and how frequently they are changing the needle. That's also very, very important, because if they are using the needle almost for continuously for 4 or 5 days, the insulin needle will be blunted, and again also that will create lipohypertrophy. We should encourage them to change the needle after 3 to 4 pricks. So that's the ideal way. And the more important thing is hypoglycemia, because while managing diabetes, it's very important. Patients should not land up in serious hypoglycemia. So that's why how many hypoglycemic episodes in the last 1 month she had, any hospitalization required to manage that hypoglycemia, and she should be educated about the symptoms of hypoglycemia regarding this palpitation, tremors, giddiness, excess sweating, and how to manage the hypoglycemia. Because we should advise them always. They should keep the glucon D available at home. They should take 3 teaspoons of glucon D. That will be rapidly observed. So the hypoglycemic symptoms will be blunted. And regarding the diet, because especially in India, the carbohydrate, especially in South India, this carbohydrate-rich diet is predominant. So we should advise them. The diet is also very, very important. So we should encourage them to take more vegetables and fiber-rich foods. And we should ask them to take 3 meals and 3 snacks to avoid the hypoglycemia. And preconceptually, it's very important to screen for retinopathy as well as nephropathy, because if they're having long duration of diabetes for more than 5 years or 10 years, the risk of nephropathy and retinopathy is there. So if they are if they are getting pregnant, the complications will worsen. So that's very dangerous. Before preconception, we should screen. That's very, very important. So it's very, very important we have to tell them to bring the HbA1c before they're planning for pregnancy, at least preferably 6.5 to 7. So these are very, very important points. Usually we should notice during the preconceptional counseling.
Perfect. Thank you, Dr. Senthil. So lots of take-home messages. As obstetricians, we are only worried, refer and let the other people take care. We should definitely know about the insulin storage, or at least if not the types of the insulin, at least we need to ask them whether they are storing, whether they have very important needle phobias are very, very vital, because we shouldn't be undermining that, because it's not easy. And very important, the importance of dietitian, because whatever is said and done, we need a certified dietitian to explain to the patient exactly according to the customized plan. We can't be telling salads to everybody because we don't know their affordability, whether it is available in their own places is very, very important. Perfect. Thank you so much. And yes, the most important thing is about the renal parameters and retinopathy. So do not forget, and please do not forget to ask about last menstrual period. What if she's already pregnant, right? And also ask them to continue the effective contraception till her endocrinologist says it's okay to become pregnant. Okay. Yes. Probably this is just a general thing, whatever already has been told. So I have just put it in a flow chart and the different types of insulin. Yes. Next, Nusrat. Are you there, Nusrat? Nusrat, are you there?
Yes,
Yes, darling. Okay, so the thing is here, what's happening here, the same lady. Okay, so after Dr. Senthil saw her blood sugars were very controlled and she was very happy. And you also said, okay, you can become pregnant. So she became pregnant on her own, and she comes back to you at 8 weeks, 5 days with a good cardiac activity. So how would you plan her further antenatal care? Okay, so what would you have to just take us through her antenatal care of plan. Yeah.
Continue her folic acid.
Mm-hmm.
Then monitor her blood sugar.
Mm-hmm.
And HbA1c.
Mm-hmm.
And at 12-week nuchal cord translucency and nasal bone thickness.
Okay. Okay. You can go trimester. That makes your life easier. If you can think of first trimester, what would you do for mother and baby? Second trimester, what would you do for mother and baby? That makes your life easier, Nusrat, if you can think in those lines.
Okay. In first trimester, we can continue this folic acid and her anti-diabetic medicines. In second trimester.
Can I just interrupt, Soumya?
Yes, ma'am.
See, I think we should, it's nice that you're telling about folic acid and all, but whenever you have such a patient, you should start with clinical assessment first. So you'll do her body mass index, you will do her checkup, auscultation, you will do her diet recall. These are things which we'll be doing on a physical, historical and physical assessment. I think that's very important. When was that last HbA1c, when was it done? If it was done 3 months back, then maybe you will have to consider using it now. So you stepwise should go history, clinical assessment, and then investigation labs that would be suggested, and medication. So if you put that systematically, trimester wise, it becomes very easy to recollect, because that's how we do it in a clinical practice, so that you will not make any mistakes. So if you go that systemic way, then you will not flounder here and there. So you can again start.
Yes, Nusrat, if you can just rethink yourself and just.
Okay. For assessment, first of all, her weight, the body in first trimester.
Okay.
Then previous reports of HbA1c and blood sugar reports.
Okay.
Blood pressure measurement.
Yes.
General
Blood
examination,
pressure.
systemic examination, that's how if you do in a clinical examination, history taking, then it becomes easy.
Yeah.
Okay,
Yes.
thank you, ma'am.
No problem. Probably I would also call Rabia, who wanted to add on. Rabia, thank you, Nusrat. That's really well done. Probably you just need to rethink the way we are doing. That's all. Okay, thank you. Well done. Yes, Rabia, are you there? Yes, darling.
No, ma'am.
So what she said, right? So you need to first, when a patient comes to you, this is what the thing is. So how would you go about from the history, clinical examination, and then you can take us to, yeah?
So as she is 8 weeks in her pregnancy, and I would just like to know her diabetes control till now. And how is the diabetes control? I would like to involve a multidisciplinary team involving my consultant obstetrician and diabetes specialist, special endocrinologist, and dietitian, and some specialized midwives in her care. And taking the things forward, I like to review her history to look for her BMI, her diabetes control, and her symptoms will be ruled out regarding her vomiting and nausea and vomiting, and what about her compliance with the medication she is taking. So that compliance, and I like to offer her the investigations of to look for her diabetes care, that HbA1c need to be evaluated. So we got to know about her control, and I will advise her to continue with the folic acid, and then aspirin need to be prescribed to her, because she had diabetes. She is first primary gravida, so she need to be at risk of having blood pressure and fetal growth restriction. So in that case, I will sensitively counsel the patient about the risk associated with diabetes, effect of pregnancy on the diabetes, and effect of diabetes on the pregnancy. She will be having repeated visits with the joint clinic where there is available, or with the diabetes and with the obstetrician. So in the first trimester, I will also like to offer her a Down syndrome screening, and she will be having her booking scan and booking labs, and afterwards in the second trimester she will be having a detailed anomaly scan, and she will be continuously on every antenatal visit. She will be monitoring her blood pressure and proteinuria, and her serial growth scans should be taken into account from 24 to 26 weeks onward. And trimester wise, I would like to monitor her HbA1c and need to be in control. And also the patient is the one who we involve in the loop of care, because she is the one who will be having her blood sugar level checking at the home. So she should be advised to, we should be very emphatic and very supportive towards the patient. So she will be monitoring her blood sugar, and will tell her about signs and symptoms of hypoglycemia, safe disposal of needles, as she is type 1 diabetes, so she is already knowing that, and hypoglycemia, and especially her family member should be with her. So detailed anomaly scan, keeping her mind, and afterward repeated growth scans. And if everything is going fine, her blood sugar is going fine, and her growth of the baby is fine, and HbA1c shows that it's normal. So we'll be sitting together at 34 weeks with the patient to discuss her plan of delivery.
Okay, so perfect. Yes, I think Davashri needs to comment on how well Rabia did. Anything she missed?
Rabia, you really did a lot of things in a nice way, but there are a few things, as Dr. Girija ma'am said, when she comes to the OPD, okay, first thing that you would tell her is about the first trimester first. You would be examining her, all those things in a systematic way. But things that we will have to tell her is, she can, if she misses, there is a high chance that she can develop acidosis, ketoacidosis, for which we need to tell her that she would have to be cautious about it. And maybe in UK, they are provided with the ketone strips, but we will have to tell her that this complication can happen. And also, she needs to be put on high dose folic acid rather than a normal dose folic acid. And also, diabetes is another important thing where we would start a low dose aspirin, that is an ecospirin, which can be between 75 to 150 for the prevention of preeclampsia. So that is another thing. And other things I think you did well, except that we would still, if she has not seen she has not been screened for retinopathy or a renal assessment, she should be done in the first. In this visit, she should be provided with all those things. But I think you did most of the things. And another one important thing is, when there is a renal problem that has been assessed, we have to think of VT prophylaxis also. That is something which we should not forget. Okay, I think that should be you've done great. And if any of the expert panel would want to add, I would be happy to hear from them too.
Yeah, can I just add something, please?
Sure.
Yes, ma'am.
I mean, the discussion till now has been very exhaustive. Davashri has added a great number of points. I will just add that along with NT-scan, a dual marker test is warranted here. Secondly, there is a rising body of evidence that type 1 diabetics generally face a lot of diastolic dysfunction. So you may also want to do a 2D echo for this patient preconceptionally or at the first visit, first trimester, first visit, like her booking visit. So it's a good idea to have an assessment before the 10-week rise in blood volume happens, because these ladies tend to go into heart failure very cryptically. And due to the diabetic status, many times it goes undiagnosed or late diagnosed. So that's one more thing you can add. And secondly, thirdly, I would also like to say that at 22 to 24 weeks, you can also request for a fetal echocardiography. So that's another thing you can add to your kitty of investigations, which you would like to recommend. Thank you.
Can I add something here, Soumya?
Yes, ma'am. Yes, ma'am, please.
Yeah. See, first and foremost, even at the time like dual marker, you should also do a uterine RTPI, even if it would have a less sensitivity. If it's high, that gives us an impetus to start her on and, to warn her that there can be problems. Now, there is recently, there are guidelines which are mentioning that if you have a clinical risk identified by a known diabetes, you are justified in starting a low dose aspirin. And now the dosage, if you look at the Rolinic study, they're talking about 150 milligram, but even you are justified in giving 75 milligram, or even the US and the Canadian countries would give 81 milligram and maybe they double it up. So if the patient is having comorbidities such as, diabetes, obesity especially, then you'd be justified. So there wouldn't be any harm in starting her on a prophylactic low dose aspirin, taking into account that she's a known diabetic. And when we do a fetal 2D echo, we can do 2-3 things together at that point in time. It's not only to screen for congenital abnormality, but you can do a cervical length assessment to predict what's the possibility of getting into a preterm birth, because they are at risk of PROMs because of the infection. You can use that opportunity again to look at the uterine artery pulsatility index and maybe, assess her risk for preeclampsia. And third thing is look at her ventricular, currently there are a lot of studies which are showing that ventricular hypertrophy and change in the dimensions in the baby can help us to identify whether this baby is going to go into macrosomia eventually. So at 24 weeks itself, because when does the macrosomia programming actually occur? It starts at 16 weeks itself. So therefore, if you have that opportunity, 24 weeks from 16 weeks till now, we have had a lot of interval where we can look at the growth parameters carefully, and that can help us in trying to improvise her care and outcome better.
Yes. Thank you. Thank you for that wonderful inputs. I know that actually I was speaking to one of my friends who is an endocrinologist. He said to me that they do routine echo. Without fail, they do a routine echo so that they don't want to, especially now, advanced maternal age is very, very common. So that's the reason it's very, very important that we need to think of all of this. Thank you so much. And I hope echosprin, the low-dose aspirin thing is cleared. Okay, moving on, all of this, of course, you need to talk to them, the levels with which they have to control without fail, otherwise they don't know what to be done. So I'm moving on because we had kept the 5 minutes only. Okay, yes, Gul. Gul, are you there? You're muted, darling.
Yes, ma'am.
Okay, so now what happens, the same lady, so it was well-controlled sugars and everything. So like she was regularly in touch with you, with the MDT team. She presents to the labor suite at 32 weeks of gestation. She feels unwell and has not felt any fetal movements after like a couple of hours after the last 6 hours. Her blood glucose control has been good until now and fetal growth has been satisfactory. However, over the last few weeks, she has been experiencing hypoglycemia. So she has missed a couple of insulin shots. Okay, so how would you proceed? What are the things which you would think in this particular scenario and how would you be proceeding?
Okay, so here this patient is coming at 32 weeks with the absent fetal movements for last 6 hours. And she's a non-diabetic for type 1 diabetes. So here, first of all, I would, I would like to assess her in the history that elaborate about the fetal movements. And then after that, I will take more history from the patient as she's in the labor suit. So is she in the labor? So I will ask about the pain and the duration and intensity and frequency of the labor pains if she's having any, and then I will also review her notes, clinical notes, and her sugar records that she's having, and she's the recording the blood sugar level at home. And as she's has been there has been an episodes of hypoglycemic episodes in the past few weeks. So I will inquire about those, and also she's she feels unwell. So I will ask further about any vomiting she's having and any feeling of along with the other history, like if she's having any concurrent illness like fever or urinary tract infection or gastroenteritis, so that can add to her sugar control, and also the concurrent infection can lead to other diabetic ketoacidosis as well. So in the examination, I will also examine the patient quickly about her general physical examination, her blood pressure, and also her abdominal examination if for the fundal height, and check for the fetal hearts during and contractions, the frequency of the contractions and the duration. And then I will listen to the fetal heart rate by Pinard handheld Doppler. And if still there are, I'm in doubt, I can have the CTG. I will ask the midwife to have the CTG, bedside CTG for this patient, as she's not feeling fetal movements. And still, if there is in doubt, I can arrange an bedside ultrasound to see the fetal hearts of the baby. And then after that, I will have the multidisciplinary team involvement for this patient. I will involve my consultant for this patient, and the diabetes specialist, endocrinologist, and the specialized nurses would be involved. And then we will discuss about, I will counsel this patient, talk to this patient regarding further care. So,
sorry to interrupt. So you have got, meanwhile, you had sent all these investigations, and this is what ABG, of course, is a bedside, and you have got these investigations. Looking at this, can you think what is happening and how would you go about now?
Okay, so after seeing these investigations, arterial blood gases and the blood sugar ketone positive, and also that the CTG is having some reduced variability. So I am suspicion of having the diabetic ketoacidosis for this patient. So so again, I will immediately start the treatment of diabetic ketoacidosis here, and I will like to have further more investigations like her electrolytes, sodium and potassium and chloride. And apart from these investigations, also start with her the normal saline. First liter of normal saline would be started along with that according to the potassium level. If these are low, then potassium can be added to the first liter. And then along with that, the multidisciplinary involvement would be there, and they will be helping us in the treatment, the endocrinologist and consultant gynae obstetrician, and also the nurses. And the intensivist, so she would be offered admission in the intensive care unit, and then start with that first liter of fluid with the potassium according to the potassium level. And then they would aims would be to correct the dehydration, and then correct the blood sugar levels, and then also the electrolyte imbalance correction. So
Thank you, I think
yes.
sorry to interrupt, we overshooted. Last question. Looking at the CTG, do you think you want to do anything for the baby right away?
So this CTG is showing the reduced variability, and also there is no acceleration. So this is again the pathological, as there are no uterine contractions. So she is not in labor. So here I would like to involve the consultant and take first that correction of the diabetic ketoacidosis, and then we can monitor the baby continuously with the CTG along with that, and further decision would be according to the patient condition.
Thank you. Thank you, Gul. Well done. So here we have two parts, obstetric part and the diabetes part. So I would let Dr. Rajasri comment about the obstetric part, what was done well and what we could improve for the Gul's part. Yeah.
Right. So she has covered almost quite a lot of stuff. But just again, repeating what Girija madam made a point a few minutes back, that when a patient shows up, first and foremost, you see her history, the clinical examination, then you go to the investigations, imaging part. First, you find the diagnosis. When she's coming with the symptoms that has been given here, you first do a blood glucose level and you check her urine for sugar and ketones. Then you diagnose that she is ketone positive in her urine ketostatics and her sugar is probably very high. She's hyperglycemia. You take her history, you see whether she has missed an insulin shot or she has had any of the precipitating factors which could have landed her up in decay. Like, see, there's a mnemonic actually, it is injury, illness, infection, and insulin misdoses. And any kind of stress, maybe surgical stress or some prolonged illness, or anything like that. So find out the precipitating factors. Then in the meanwhile, you have ordered for these investigations. So any pH less than 7.3, bicarbonate levels less than 7.3, these are all go in favor of a diabetic ketoacidosis. And since she is just 32 weeks of gestation, we are not going to do anything much with that CTG on your hand. So basically, you need to hydrate her. You need to start her on her IV insulin. You need to treat the precipitating cause. What led her to this condition? Whether she has been ill, fever, even urinary infections, which are very common in pregnancy, can land up a patient in a decay. So you have to treat the precipitating cause. And then you go ahead with your further management of the obstetric part, and the medical part should go hand in hand with your MDT. Another thing I would like to say is, what would be your target for getting the ketones and sugars corrected? So the ketone should reduce at a rate of about 0.5 millimoles per hour. Your bicarbonate should reduce at a level at the rate of about 3 millimoles per hour. Your glucose levels should reduce also again at 3 millimoles per hour. So you should try to get around a ketone levels of less than 0.6, a pH, blood pH of 4 or approximately 7.3, and the anion gap should also be reduced. So these are the targets of treatment which you cannot suddenly start her on some extremely aggressive treatment, because then you will develop side effects of the treatment. So you have to follow a particular protocol of hydration, putting her on IV insulin, monitoring her periodically, and then treat her. About the insulin therapy part, I think, would you like Dr. Senthil to give his comment?
Yes.
I can add something from the obstetrician point of view is the moment you see something which can be primarily done, like you send the labs to the patient, you did an NST. Likewise, you can also order an ECG. This is something which we can do. Do an oxygen saturation by a pulse oximeter. Strip on her to a multi-para monitor because she's in a DKA with a pregnancy. And meanwhile, your reports come in, your endocrine advice comes in, your medicine advice comes in. So basic things which we as OBGYN specialists can do, we should never falter on. So doing ketones, doing sugar, sending labs, doing ECG, NST, and all these things come under that purview.
Yes, ma'am. Thank you very much. Dr. Senthil, I think we know about a lot of theory, but probably as an obstetrician, what do you expect us to do? Because probably you guys will come in and take care of the rest of the thing. What's the basic thing which you want us to do? That's what I'm interested in. All this 3.3, 3.3 to 5.5, we all know all of this. But what do you see the most thing which is missed all the time in your clinical practice? That's what I'm interested in.
Yeah, so in this case scenario, she has always, we should educate the patient. If they are having hypoglycemia, better to consult the diabetes educator or the treating physician, how much insulin has to be reduced, especially during pregnancy. That's very, very important. Because if they are reducing drastically, if they're taking, instead of, if they're taking 10 units, if they are suddenly changing to 5 units, so there will be rebound increase in blood glucose level. So that can precipitate DKA. So we should find out what is the cause for this hypoglycemia, whether patient is having hyperemesis. So accordingly, we should adjust the dose of insulin. If patient is on conventional insulin, better to switch over to analogs, because these insulin analogs will have less incidence of hypoglycemia. And at the same time, if patient is having frequent episodes of hypoglycemia, especially type 1, we can advise them to switch over to insulin pump. So the insulin pump will have less glycemic variability. So they'll have smooth glycemic control. So one thing is that the insulin pump is costly. Few patients cannot afford. But nowadays, insulin pumps are available rental this thing also. So they can avail for 1 or 2 months before delivery. So that's also possible nowadays. And when they are landing up in DKA, so ABG is the first thing. So always before starting insulin therapy, we have to hydrate the patient. Don't start first away with insulin, as we all know, because hydration is very, very important. And if potassium is less than 3.5, don't start with insulin, give potassium correction. And hourly monitoring of blood glucose is very, very important. And in many centers, the checking of this blood ketones is not possible. Even in tertiary care centers also nowadays, the blood ketones is not widely available. So always go by serum bicarbonate and blood glucose level, and always this patient will come with tachycardia, patient is in DKA. And that's very, very important, how the heart rate is coming down. That's clinically we have to monitor. And hourly this urine output, I think it's missed, I think. Urine output is very, very important, because we will be over enthusiastically will be replacing the fluid. If patient is coming in acute kidney injury, especially in DKA, patient can land up in pulmonary edema. The urine output is not properly maintained if you are giving over IV fluids. So it's very, very important to monitor the urine output hourly. So according to the urine output, we have to give the intravenous fluids. And if blood glucose comes below 250, don't replace NS with DNS, because we should not stop insulin. And don't go by urinary ketones, because urinary ketones will be misleading in DKA. Because if patient is recurring in DKA, the urine ketones may be high also. So don't go by urinary ketones. No need to monitor urinary ketones. Go by serum bicarbonates. Because in many centers I have noticed that urine ketones 2+, 3+. From 2+, if it's jumping to 3+, don't get panic, because If patient is recovering from DKA, what happens? There'll be a paradoxical increase in urinary ketones. So no need to panic. I'm saying the urinary ketones going from 2+ to 3+. If bicarbonate is improving, that's quite well and good. So these are the important things we should concentrate.
Thank you, sir. So basically the essence is the clinical management. So I think all of you, I know that most of them are exam going, so they want to finish the task quickly as they have 10 minutes timer. Most of them, whoever has attempted, are part 3 exam going candidates. So that's why they're trying to fit in everything together. And the most important thing is...
Soumya, sorry if I may interrupt you. I want Dr. Senti Raja to also speak little bit, at least in 2 minutes, about 2 things, because now, especially in a patient of DK at 32 weeks, we as obstetricians would think of maybe an imminent delivery shortly. And therefore, we consider giving them antenatal steroids and magnesium sulfate for neuroprotection. So when should it be ideally placed now with this situation, according to you? Because that would be a great insight for all of us to practice.
Yeah, if you are planning to give steroids, especially not in DKA, maybe, ma'am, you are asking DKA steroids, you are asking?
Once the DKA stabilizes, we would consider giving a neuroprotection magnesium sulfate and antenatal steroids will definitely be given, because she may land up in a delivery shortly. Yeah.
Yeah, magnesium sulfate will not impair any this glycemic status, but steroids, if you are planning to give steroids, after 4 to 5 years of giving steroids, insulin will shoot up. So whatever the insulin they are taking, if they are taking Actrapid 3 times 10 units, so they may require 15 units or 20 units also. So all you can increase by 5 to 8 units for each dose, because steroids will increase the blood glucose level even up to 300, 400 also. So whatever insulin they are taking, you can increase initially 5 units. Then after breakfast, you can check it still like for lunch, instead of 15, you can go up to 20 units also. So depending upon the blood glucose level, you can increase the insulin even up to 5 to 10 units for each meal. So you can, in those scenarios, better to check pre-meal and post-meal, because depending upon the pre-meal, you can give the correctional dose of insulin. So it will take 2 to 3 days for the blood glucose level to stabilize. So to check 6 times daily when you are giving steroids, accordingly, we can increase the dose of insulin. And that steroid effect will persist for up to 5 days also. Even you can continue the insulin infusion. You can start insulin infusion also to control the blood glucose level during that period of time.
Okay, perfect. Yes, I do agree, because like what we do here is I think everybody does the same thing, admit and then give steroids and titrate the insulin dose so that you can be at peace. Of course, you can't be sending them home. So again, the essence is do not forget to advise the mother at discharge what she has to be doing and how she has to probably come back, the alarming symptoms and precipitating factors what she had, because she stopped because she had hypoglycemic effects. So patient education is very, very important. Let's move on. Yes, Hira, I think you wanted to do the next scenario. Hira, are you there, darling?
Yes, ma'am.
Yes, darling. Okay. The thing is now what happened. So actually she was like well controlled, whatever. So she presents to you at 37 weeks one day with a labor pain. At 7 a.m. in the morning, she presents and she has taken her insulin yesterday night. Her blood sugars were well controlled after DKA. Thankfully, everything went on well. So your midwife checked the GRBS, it is 90 milligram per cent or 5 millimole. And you look into the notes, her estimated fetal weight of the baby is around 4,200 grams. So on examination, it is a cephalic presentation, longitudinal lie, cardiac activity is good, CTG is fine. Vaginal examination, she's in a very latent phase of labor. How would you proceed with this now?
Okay. First of all, I will ask for just a minute. Sorry. First of all, I will like to know her observation. Okay.
Hira, we can't hear you. Probably you're muted. I'm not sure. Yes, you're muted. Hira?
Sorry. It was
No
mute
problem.
and I was talking. I'm so sorry.
No problem. Yeah.
Okay, I'm so sorry. So first of all, I will like to do the observations and uterine contractions, and we will discuss the pain management options, and we will discuss that there is a baby's weight is
4.2 kg. So it is a macrosomic. Can you hear me?
Yes, yes, we can hear you.
Yeah. So, so we will discuss the what could be the if maybe delay in the progress of labor and maybe need of the cesarean section because of the this macrosomic baby. So we might have complications of like shoulder dystocia. We will and perineal tears leading to the 3rd degree, 4th degree. And we also involve the anesthetist to be reviewed for the anesthesia or maybe need of spinal, and endocrinologist and monitored blood sugar. And during the labor, we will monitor hourly blood sugar to maintain at 4 to 7 millimole per liter, and maybe need of insulin during the IV insulin during the labor, and continue CTG monitoring. After the delivery, we will monitor her.
Hold on. We are still in the labor. Okay. Yes, Geja, want to add on to what Hira said?
Yeah, first and foremost, let's go back on the slide.
Yeah, sorry, ma'am. Yeah.
Yeah. Is first of all, you can see that her expected fetal weight on the last ultrasound was 4,200 grams. Now, the question is, when was the last ultrasound done? Because normally, if it's a diabetic who is under control, we would do it at around 34 weeks or 36 weeks. And if it was done at 36 weeks, today she's come a 1 week later, 4,200 grams must have now increased in size. So that is something which is important. Secondly, it's also a reflection that probably whatever sugar attempts control were made during her antenatal period haven't worked well. And therefore, she had an insult of a DKA, or maybe, this is another patient. She did have a problem. So these things have to be kept in mind. So 2 things are here. The mother is probably an uncontrolled diabetic and the baby is a macrosomic baby. And therefore, we will have to speak on her. Now, if you look at her pervaginal findings, which you mentioned with the CTG normal, 60% efface 2 to 3 centimeter dilated. Additional information, what would you want to have here? Because we do not know whether she is a primigravida or a multigravida. Let's consider that she is a primigravida. So would you want some additional information now that she's in labor?
First of all, we will discuss the plan. Sorry. Station, I would like to know the station CTG.
Or abdominally also, if you can see that you have mentioned longitudinal lie, cephalic. Yes. Anything else on per abdominal examination?
Prime contraction I have asked, and I would like to know the station of the station of the baby.
Whether the head is engaged or floating.
Yes.
Head is engaged or floating, because sometimes if the babies are too big, their shoulders would preclude from engagement. So the head, whether it's engagement or not, is important. Anything else on pelvic examination apart from the cervical score that we have? We should also do a pelvic assessment.
Should I say that because it is not recommended, because otherwise clinically we usually do this?
It is not recommended antenatally. Okay. Now she is in labor. When a patient comes in labor, then we have to do an assessment of the pelvis. You understand? Yes. So because otherwise anything else you would want to see about the baby, because now we are seeing, you have said term size, longitudinal, cephalic, good. This is typical midwifery finding, but we are obstetricians. So additional information on per vaginal finding. We want to also see the position of the baby. That would be important, whether it is a LOT, LOA, ROP, because that's going to definitely matter as she goes into labor.
I think she's in very early labors. That's why maybe that will be moved baby. So it's in my point of view, it is too early, like 2 to 3 centimeters. She will go in labor. However, baby is 4.2. It will be difficult for. She will go in labor.
So then what to do now? Like at this point in time, would you want to talk or do something about it?
Yes, I have, as I told you, as I told that we will discuss the plan and complication of the good size baby, like macrosomic baby, and pain management options and continuation of the insulin fluids and pain management, and neonatologist, endocrinologist, anesthetist will be involved.
There are certain things, because we are speaking on an international level. Every country specific issues also exist when it comes to the expected birth weight.
Yeah.
You understand? Because the definition of macrosomia, or a baby which is small for gestational or large for gestational, would depend on the race. And it would definitely
macrosomia,
differ.
they have given that macrosomia is 4 kg and large for gestational age is 95th centile above.
Yeah. Yeah. So that's one more thing which we should see when we are looking at the growth parameters. Excellent. What you're saying is which centile growth it is. You understand? So that will also matter. How are we going to guide this patient for delivery? Because this is the time when we'll have to sit and counsel the relatives and the patient. Because as to where are we heading? Are we going to go in for a vaginal delivery? Or are we going to consider...
We will tell all the complications
of
vaginal delivery and cesarean section.
Correct.
And risk of PPH2, which I forgot to say, which is very important.
What is the reason why will there be postpartum hemorrhage?
Yeah, I said shoulder dystocia, vaginal tear, but I didn't say PPH because it was, however, it was very important.
Yeah, PPH and something before PPH, like you said, shoulder dystocia, something before shoulder dystocia. There can be protracted labor. It can be a prolonged labor.
Maybe cord prolapse and like this.
There can be, yes, absolutely.
Maybe she is a high BMI, so we have more concerns for that.
Meconium stain like her.
Yes, ma'am.
We'll have to control her sugars. We may have to start her on an insulin drip, glucose insulin drip now that she's in labor. Monitor her sugars more closely. Okay? Yeah.
Yes, ma'am.
Good.
Okay, perfect. Thank you, ma'am. Yes.
Dr. Soumya, what are your comments?
The same comments. What I know that you're asking in terms of part 3. You're good with the part 3, don't worry. But this is not part 3. This is HRO discussion. But yes, I do agree because you're thinking of the exam points, but the clinical points, whatever Girija ma'am said, I completely agree because we should look into the case as a whole. Okay, perfect. And autogram, guys, don't forget, that's very important. Yes, perfect. Thank you, Hira. Thank you, ma'am. Thank you. That was a wonderful discussion.
Thank you so much. Thank you for giving me the chance.
Yes, Humaira.
Yes, Dr. Soumya.
Yes, now you explained her everything. She wants to have a normal delivery. So you are in a setup where epidural was available. So she's fully dilated, head delivered, shoulder suspect.
Yeah, so this is a case of shoulder dystocia, which is an obstetrical emergency. It requires prompt action. So I will press the emergency buzzer and call for help immediately for all the staff to be available, inform my consultant, the senior midwife, and my junior registrars. So we'll start with first of all, ask the patients to stop to push and for communication that we are going to do some maneuvers, and also we'll bring the patient to the bed, edge of the bed, and we'll communicate with her that we are going to deliver the baby by some extra maneuvers. So we'll just debrief her about the situation. Ask the midwife to pass the wide bore IV cannulas, and first of all, McRoberts maneuver is the first line that we would opt for her, which is adduction and a hyperflexion of the hips. Then at the same time, if it doesn't work, because 90% of the deliveries are done with this McRoberts, stop pushing and stop fundal pressure. This is the most important thing, and stop syntocinon. Also, it's important that suprapubic pressure will be applied, and one of the assistants will be applying the constant rocking motion, the suprapubic pressure. Then if this doesn't work, then we have to opt for the other maneuvers, the internal maneuvers. So make sure that episiotomy would be required to make some enough space to do these maneuvers. So wood screw maneuver or the reverse wood screw maneuver, Rubin maneuver, they will be applied. If they don't work, then informing the consultant is important because the third line maneuvers will be done by the consultant. So we have to repeat all these maneuvers. We have to put the patient in for all fours for repeating all these maneuvers. If still these don't work, then the third line maneuvers will be opted, which are the disruptor maneuvers. And pediatrician will be in attendance. Yes, pediatrician will be in attendance.
Pediatrician and an experienced obstetrician.
Yes.
Okay. At the level of your training level, you must always say that such a patient comes, it's going to be an expert obstetrician also around to take. There's no harm in taking second opinions in such situations. You understand? Because they
Yes.
can cause a lot of challenges, and we should definitely not suffer from diffidence, because when we make mistakes, they last with us for lifetime. So always have a senior person around, and then there's no harm in having a team approach and a sort of joint decision making. So I think you explained the manuals quite well. What is very important, however, is that these are the ones which you should always remember. 1, 2. Secondly, one of the most important things why shoulder dystocias would also happen is that you have fiddled with the baby a little more. We become desperate, especially under epidural analgesia. Today, the guideline says that the second stage of labor is for 4 hours. 4. You understand? If it's under epidural, the patient is under. So if she's gone second stage, if it's she's fully dilated, don't get desperate, because macrosomia, shoulder dystocias can also be iatrogenic, where you have unnecessarily pulled and pushed the patient. Many times her body, the perineum, will take care and the baby will come down. So always remember this under epidural, especially if it's a primary, 4 hours. If it's a multip, then it's 3 hours. If it's non-epidural analgesia, then it can, for a primary, it is 2 hours, 2.5 hours. And if everything's fine, you can still wait on her, extend it till 3 hours. And for a multi, it would be 1 hour. So remember these, because these are sometimes commonly asked questions about epidural non-some. All patients do not opt for epidural also. We do have patients who would choose not to use it, and then we should be knowing exactly how long are we monitoring. Likewise, you must be aware of the second stage brady. Now, can you tell me the reasons if there is second stage bradycardia? What are the reasons which you should look at in this particular big baby? One of the commonest reasons of physiological second stage bradycardia is what? Can anybody tell fast? Second stage bradycardia.
Head compression is, but it is.
Yeah, head compression. Vagus
compression.
stimulation. Simple, isn't it? And then the vagus nerve gets stimulated. But you must be on guard in these babies. What can also be the reason? They are suffering maybe from hypoxia. There can be a myocardial hypoxia in this baby. It's a big baby. You understand? So whenever you're interpreting your CTG, you have to be very careful in a diabetic baby. You understand? Because macrosomia doesn't mean healthy baby. They have a concentrated blood. Their hemoglobin is very high. They have huge erythropoiesis. So they're generally hypoxic babies. So this has to be remembered always. I think we are done. And then after delivery, you are going to practice universally active management of third stage of labor. That risk, checklisting is going to be there, because you're going to give her oxytocin, which is the universal guideline. You definitely know whether she is an asthmatic or not asthmatic. If she's an asthmatic, no prostaglandin to her. You can then switch to methylargometrin. If she's a hypertensive, no methylargometrin. And then the best thing would be a combination of oxytocin along with maybe misoprostol orally. So these things have to be ready, because she is a potential patient of going into postpartum hemorrhage. So you have to practice active management of third stage of labor and prophylactic treatment for prevention of postpartum hemorrhage.
Perfect, ma'am. Thank you.
Then also check for perineal tears.
Yeah,
Yes,
that's
perineal tears
possible
and PPH.
examine the placenta, look for perineal tears, cervical tears. Very important. And there is no harm in taking these patients in an operation theater for a delivery. Because you may require to use instrumentation, maybe a Kiwi's forceps or 1-2s, or maybe a forceps. So you can take her in an operation theater.
Yes. So thank you, ma'am. Thank you for the discussion. Yes, probably guys, just a few things about the manuals.
One more thing, Soumya, before we forget, is postpartum hypoglycemia can happen suddenly in these patients. So that we have to not forget. Yeah.
Yes, guys, what is this maneuver? Very easy. Can you all appreciate?
Roberts.
Like Roberts.
Yes.
For that, you have to take the patient to the edge of the table.
Edge of the
can't
table.
do Mac
Yes.
Robertson on a flat surface.
Yes.
It has to come on the edge of the table, and then only you can give it.
Yes. Edge of the table, stop pushing. All that is the general things which all of you must remember. And don't remember your pediatrician in the end. You have to call them as early as possible. Yes. One more question to go. Before that, guys, we have a 3 months hybrid course. which means online teaching as well as offline, helping to improve your skill set. Okay. So like probably from the resuscitations, from maternal collapse to all the obstetric emergencies, we would be helping you to do better in a live station skill set. It would be done in dry lab. Whoever is interested, please get in touch. The registrations we have already started. The last question, I think I have one more thing. Yes, I think Rabia said again, you want to answer. She's about to be discharged home. What is the advice for her? So shoulder dystocia was managed well with the microbots. Baby has no problems. She's doing really well. What is the important advice? Probably you have 1 minute only, Rabia. Go on.
So in terms of her advice, we'll advise them some regarding her diabetes and some general advices which we give to every postnatal woman. So in terms of advice regarding her diabetes, that she need to be continuing with the pregnancy insulin, or we need to get her in touch with the endocrinologist. So her insulin which she need to be monitored, that need to be given her continuously, monitored the blood sugar and information about hypoglycemia.
Sorry, Rabia, you're muted, darling.
Okay, so she need to continue her insulin, her blood sugar level monitoring, and signs and symptoms of hypoglycemia, especially when she was having breastfeeding. So advice about breastfeeding, that should be given to the patient, and about contraception, that advice to be given so she can have the appropriate contraception and bud spacing. VT risk assessment need to be done, and also her follow-up visits, because these patients are at increased risk of having wound infection because of poor diabetes control. And that need to be told to the patient, and patient need to have a regular follow-up with the joint clinic at 6 weeks. She required a follow-up, and the midwife will be visiting her at home, and a detailed discharge summary will be given to the for the follow-up of this
Your time
patient.
is done. Thank you, darling. Thank you so much. So just remember, mother's hypoglycemia, baby's hypoglycemia. And yes, very, very important. Talk to her about the insulin dose. Probably your diabetologist or the endocrinologist would decide the dose. Very important contraception. Okay, so you can give copper IUCD for them. That is something which you can easily give. But rest of the things all come under category 2. So make sure that you, depending upon her risk, so you need to individualize and give. Of course, you need to be, baby would be definitely monitored for hypoglycemia. Then only she'll be sent home for the discharge. Very important. Tell her to like probably spacing of pregnancy is their choice, but you need to tell them how important it is. And yes, if at all, if they have a retinopathy, don't forget they have to be monitored monthly for 6 months. But that's important. Okay. Okay. So I think that finishes our panel discussion. First of all, the take-home message I would tell you is basically you treat the patient along with the disease. You can't be, I could see most of you are have a super knowledge, but you want to, you are forgetting that you are dealing with the patient. Okay. So I think I had a very, like probably I learned so many things, and thank you for all the panelists. I'm not taking individual names. It was really, really wonderful, because all these practical points, you know, we tend to remember, and probably we instill for everybody, the practicing obstetricians. I won't call them students because everybody is dealing with the patients. So probably it helps in a better woman's health, and probably we can save lots of mothers, and we can save ourselves as well. Thank you everybody for the wonderful session, and it was really indeed my great pleasure. Thank you guys. Thank you so much.
Thank you, ma'am, for having a quick revision on the diabetes. Thank you so very much. You guys are great, ma'am. Thank you so much.
Thank you. Thank you. Thank you. Yes, anything if panelists wants to add before we
I
leave?
want to just add now, whenever you're talking of any HRO patients now, when you're diabetes, heart disease, hypertension, always talk of long-term issues. Like you will put her under surveillance, because that's become the, you know, that's a nice current hot bun now selling everywhere. So it shows your, you should always say that, yes, she'll be, because they are at risk of future cardiovascular diseases and things like that. So you would be talking on those lines always. Like it doesn't end with contraception as it used to end in the past. Today we will also talk about their future health.
Yes. Perfect. Thank you. Yes. So thank you, everybody. Thank you, everybody. good night. So hopefully we will be doing lots of sessions like this in future. Thank you everyone for joining. Have a great day. Thank you.
Bye-bye.
Thank you. Bye. Bye. Thank you.
Thank you.
I want to reconfirm one thing, what Dr. Girija ma'am said, like for epidural, it is 4 hours. We have to wait in the second stage. And what we really follow is multi 1 hour without epidural.
Nikita,
and
you're talking about the NICE guidelines, sweetheart. That is for the exam, which you need to remember. Every country has a different guideline, so remember that. Okay.
No, I am telling you, this one has come recently. Like I'm talking to you on the basis of what yesterday Professor Arul Kumaran, the RCOG ex-FIGO president and the chairman of the RCOG, spoke in his talk. Yesterday he talked on induction of labor, and in that he mentioned that this is the guideline which is saying that we can definitely wait for 4 hours. So it's based on the RCOG guideline itself that I'm telling you.
Yes, ma'am. But the reason they have come out with a NICE guideline, ma'am, which is totally different. That's why they are confused. They have an exam. So that's why I was yes.
So even if you say little that much also, or anybody contest, you can always say, yes, we know that there is an updated guideline.
Yes.
Okay. And don't go into any controversial fights with the examiners.
Yes.
Okay.
Yes, ma'am.
Thank you, ma'am.
Thank you. Thank you, everybody. Thank you so much.
Thank you.
Thank you.
Bye.
Bye-bye. Bye. Thank you.